Good afternoon. Firstly, I would like to thank Medronic for giving me the opportunity to speak to you today. As you well know, implantable cardioverter defibrillators and cardiac resynchronization therapy have been shown to improve survival beyond that afforded by optimized drug therapy. Well, since the acceptance of indication of ICD for primary prevention and the usefulness of cardiac resynchronization in mild heart failure, the number of cardiac device implantation has increased. In fact, nowadays in Europe, around 2 million patients have a cardiac device that will require around 4 million of follow-up visits. The standard of care of this kind of device is an in-person evaluation the first month after the implantation and every 6 months thereafter. This volume of visits adds burden to clinicians and creates the need for a more efficient solution. Moreover, devices have evolved. They not only base or deliver life-saving therapy, it also collects several measurements that would be very useful for us. This information has a special value in patients with a CRT device. A continuous or at least a quick access to it may be worthy. The development of technology has meant that nowadays some tasks that usually require to use a physical presence like banking, shopping, booking travel, now are routinely cared from home or work. So why not apply this kind of connectivity to our CRT patients? In response to a clinician request or a predefined schedule, the device transmits the diagnostic information to us, and we can to a central server, and we can access to it through a secure internet interface. Despite early concern, remote monitoring has demonstrated to be secure, efficient, comfortable for patients, and has several benefits for them. One of them is the psychological reassurance of a more constant surveillance of the device. The CONNECT trial demonstrated that remote monitoring has allowed doctors to make clinical decisions sooner than in patients with a standard follow-up. Also, it demonstrated that it's associated with a shortened stay in hospital. But, like in every great medical advance, clinicians are looking for a survival advantages, and that was the objective of the EFFECT study. The EFFECT study was a multi-center clinical trial that included 987 patients. 499 patients adopted the remote arm. That study aimed at measuring and comparing the outcomes of patients with remote monitoring and patients with conventional follow-up visits. The primary endpoint was the rate of death and cardiovascular hospitalizations. Here you can see the results. The outcomes were significantly better in patients with remote monitoring, although globally there were less visits in patients with remote monitoring. In patients with CRT devices, there were no significant difference. Here you can see the univariate analysis and the multivariate analysis, and remote monitoring turned out to be an independent protective factor, as was the use of a CRT device. Here you can see the Kaplan-Meier estimation of time, and patients with remote monitoring displayed a significant higher event-free survival. Well, with the current evidence, we should recommend remote monitoring for all of our patients. This is the recommendation in the guideline, European guideline, a class 2A recommendation with A level. But in the recent HRS Congress, a new statement of a new expert consensus statement has recommended remote monitoring as class 1 with A level of evidence. Well, I have said that devices can provide us very useful information. What is this? We have several data about heart failure management. One of them is the baseline heart rate. This is very useful, for example, to optimize treatment. And night heart rate is a good marker of autonomic tone. An elevated night heart rate is associated with higher risk of hospitalization for heart failure. We can measure the heart rate variability. Devices collect data and make measurement of atrial intervals, intrinsic atrial intervals, not paced. And they calculate the median of 5-minute period, and this is called STAM, and the lower STAM is, the higher the mortality is. We have data about activity, that it's a good reflection of the patient's functional capacity. And the famous optimal, we have data, we know that the fluid accumulation it can be weeks before that the patient develops symptoms. A decrease in the impedance, in the intrathoracic impedance, is associated with elevated preload and extravasation of the fluid to the lung. But all the parameters should be always taken account and combine this because always the combination is better than one parameter alone. We have information about atrial and ventricular arrhythmias and the delivery therapy. And we have measurements about the integrity system. One of the concerns was the management of such amount of data, but the ability to customize alerts streamline the prioritization of data analysis. Well, we have a lot of data, but if those data are not organized and are not analyzed, we can lose a lot of information. Medronic creates this follow-up, 2.0 follow-up, that is an application that transforms individual data in a global analysis, so it may help us to make our clinical practice more efficient. By means of Cardiac report, this is the difference with Discovery Link, that is an application in Europe. We can ask a lot of reports. We can obtain information about types of devices, biventricular pacing percentage, core alerts, type of therapies, effectivity, time until the first therapy. All of these are real graphics of a report from our hospital. And you can see, for example, information so illustrative like this. With this graphic, you can see the evolution of remote monitoring in our hospital. And Medronic took a step forward in Spain and creates a Scoop platform which analyze all the devices implanted in Spain. Thanks to this initiative, several papers and abstracts have been published in recent years. Okay, this is the theory, but if you let me, I'm going to show you some slides about how we use it day to day. Currently, we are following up around 300 patients, and as I said before, the number is increasing. In our hospital, we decide to schedule a specific time to review remote monitoring in the morning. It is managed by nurses. We have very qualified staff nurses, and they review remote monitoring from 8 to 10 a.m. They review the alerts, they consult us, they phone the patient and schedule visits as necessary. We usually program monthly transmissions. The more frequent events we find are new atrial fibrillation, our nurses keep track of which patient takes anticoagulation, and they know when they have to advise us or notify if a patient needs new anticoagulation. They phone patient and we schedule visit to start anticoagulation, or because without remote monitoring, the problem is that you don't notice that a patient have an atrial fibrillation until the scheduled visits or unscheduled visit due to symptoms. But embolic systems are not the only problem for this patient. For example, atrial fibrillation makes decrease biventricular pacing, and patient it can worsen heart failure. Sometimes patients they usually know that they have a shock, but for example, ATP is painless. So patients can have several ATPs and you don't know until you see the patient in a standard visit. So without remote monitoring, you don't know what is happening in that patient. We have alerts about device dysfunction, so you can take a decision before. This is the alarm we program. Some of them are not programmable, and some of them have an adjustable threshold, like the number of shocks delivered in an episode. For example, we set it up for 1 shock, or the ATP, the AF burden, or the threshold for the optimal fluid, we usually increase to 120 to 130. Okay, this is a Spanish cat because we eat at 2-3 o'clock. I have time for some example. Well, this is a patient with a recent implant of a CRT device, and in the first report we saw that he had atrial fibrillation and was asymptomatic. But you can see that biventricular pacing decreased. In the EGM, you can see the atrial fibrillation and the decreased biventricular pacing. We called him, we initiated anticoagulation, then antiarrhythmic drugs to try cardioversion. Sometimes, in a quick look, you can see or imagine the functional status of the patient. It seems clear that this patient, the atrial fibrillation makes him to be bad, because when AF episode increase, activity decreases, and you can see change in optimal curve, and when AF stop, the activity increases again. This was a patient with a shock. What is interesting is when we found the patient, he was surprised because he didn't feel anything. It was while he was sleeping. And I show you this case because I would like to stress the excellent work of my nurses. They always thoroughly review all the detail of the reports, and they saw this. And when she analyzed that, she viewed this. It's not exactly as non-sustained VTs. As you can clearly see, it's oversensing, and there is an inhibition due to the oversensing. The patient didn't have an escape, so fortunately we had the remote monitoring to catch it immediately. There are interrogatory alerts. This is a patient with an increase of impedance. And this is an unfortunate case. It's a patient that was a clinical responder, but in the replacement she had an infection and an LV epicardial electrode lead was implanted. But in the first report after discharge, we saw an increase in the capture threshold. In fact, the LV lead had been dislodged. And in weaker patients, when it rains, it pours, and the next event in this patient was an atrial fibrillation. In each report, we can obtain the current EGM, and this is useful. Sometimes, like in this patient, he phoned us because he felt strange, he felt palpitations, and we could see that was premature beats. Well, some considerations. I think it's clear that remote follow-up is good for our patients, but not only for CRT patients, for all of our patients. So we have the technology, we know the prognostic benefits, so I wonder, we should offer a 24-hour service, and it is unethical, it is ethical not to offer it. At least we should select which patient would benefit the most, perhaps those with a higher risk of developing AF, or a patient who lives far away from a hospital. I think, on the other hand, legal responsibilities shouldn't be only applied to doctors. Patients should be aware with the remote monitoring, and they should notify when they go on holidays and they don't take the transceiver, or to update the telephones. And for us, it's very useful, the data, but I think for IF doctors would be more important the access to those data. At least in my hospital, remote monitoring is carried out by the EPL, the Arrhythmias unit. And moreover, I think a hospital manager should be aware of the importance of remote monitoring and should provide more human resources to assume it. To conclude, current devices collect very useful information for the management of heart failure. In fact, remote monitoring has become a worthy and essential tool in follow-up of CRT patients. Remote monitoring helps clinicians to detect and respond early to adverse events and make the clinician practice more efficient, so much so that we know that the remote monitoring permit less hospitalization and improve survival. So I think with the current evidence, perhaps we have to consider that it's not unethical not to offer it to all of our patients. But however, doing so will require more human resources. Thank you very much, and have a nice day in Seville.